So let's talk about this hearing aids and cochlear implants preserving brain function. Like I said, they actually can. There's some very new data just published a few months ago in the Hearing Research Journal that shows that with the proper characteristics, hearing aids can be very sparing of the damage that hearing loss can do to the brain. And we'll talk a little bit about that also. Where do we get this idea? Well, it starts back in 1999 on the next slide with a man named Dr. Raymond Hurley. He was working at the VA at the time, and he discovered that at the time, veterans could only get one hearing aid, even if they had hearing loss in both ears. He discovered that the unaided ear was degrading more rapidly than the aided ear on these folks. So he got to wondering if maybe something was going on above the ear itself in the pathway to the brain, and data suggests now that he was exactly right. This onset of auditory deprivation, as he called it, occurred from veterans who had one hearing aid on one ear and needed one on the other but couldn't get one through the VA, so they were showing more degradation. So he had sort of something of a captive audience to show that this auditory deprivation was producing muddiness in the clarity of speech. Then, back in 2012, this guy here named Dr. Frank Lynn, who worked at Johns Hopkins, had a pile of old data in front of him from the Baltimore Longitudinal Study on Aging, 1,500 people to be exact, that they had done hearing tests and MRIs on these people every single year for over a decade. So he was able to look at the hearing levels and the MRIs and determine that there was some relationship between what was happening to their brain and based on their degree of hearing loss, which is the next part of this slide. He discovered specifically that in addition to the brain shrinking 1.03 cubic centimeters quicker on the people with hearing loss, they were also showing more tendency towards what he called all-incident dementia, of which Alzheimer's is one of those disorders. I said, he discovered that based on his research, mild hearing losses made you twice as likely to have dementia as those people who had all the other risk factors except for hearing loss. People with moderate hearing losses had a 3 times greater risk, and people with severe hearing loss a 5 times greater risk. So he got to wondering, why could this be? He theorized that perhaps we're overworking the brain when you have hearing loss, trying to fill in the missing elements of what was being said. This brain overwork theory has been around since 2012, but it wasn't until just recently that another person, which is the next slide, and he discovered some other relationships that were of interest. People with hearing loss are more likely to have falls, which is the #1 cause of accidental death in people over age 65. People with hearing loss are more likely to have extended hospital stays and more hospital stays, a lot of times due to the fall risk. But there were all these other variables associated with hearing loss that weren't present to such a great extent in people who had all other risk factors except for hearing loss. Then, this woman from University of Colorado at Boulder discovered something that helped explain all of this relationship between dementia and hearing loss. Specifically, she started doing lots of brain recordings, functional MRIs, if you will, on people that had normal hearing and people that had hearing loss. And what she discovered was very important. She noted that people with even mild early onset hearing loss were showing different brain activity than people who had normal hearing. For example, people that have normal hearing, when they're doing an auditory task, like listening to this presentation, are using the auditory area of the brain. Well, that makes sense. It's an auditory task, so you're using the auditory area of the brain. No surprise there. And that's exactly what happens if you look at her functional MRI. You see that little red spot lights up on the brain in the auditory area of people with normal hearing, just like it should. But that's not what happens for people with hearing loss, even mild hearing loss. People with mild hearing loss are using the frontal area of the brain when they're doing an auditory task, which is a whole different use of that area than what was customary. Next slide. People with hearing loss are using the frontal and prefrontal area of the brain for hearing and listening. So, you might ask the question, what should that frontal area be doing if you had normal hearing? Well, the answer is, it is associated with attention and memory. Well, gosh, that's what dementia is, loss of attention and memory. So suddenly, we see an early warning sign that the brain is being misused by people with even mild hearing losses. So, to summarize, people who are hard of hearing are misusing the brain. They're using the frontal area, the memory area, to do auditory tasks. And Dr. Lin had said he thought that this was because of the brain overworking. Could it be that the brain is too busy doing listening to do its memory task? Well, that's exactly what they believe. And therein lies your relationship between hearing loss and memory problems, dementia as it is known. And if you look at people who have dementia and you look at the areas of the brain that are damaged, yep, it's the frontal and prefrontal areas. That is where memory is stored, and that is where dementia strikes. Alzheimer's being one type of dementia. So Dr. Lin's guess about what was causing this problem ends up being pretty accurate, with some data now supporting it through functional MRIs. And it's not just the auditory area that's having these problems. It's also the visual area. Now, when people with normal hearing do a visual task, they're going to light up the back area of the brain because that's where vision perception takes place. Makes perfectly good sense. But guess what? That is not what happens when people have hearing loss. Let's go to the next slide. People with hearing loss are using the auditory area of the brain to do visual things. So this reorganization of the brain isn't just taking place in the auditory area, but it's taking place in the visual and the memory area. Essentially, hearing loss is scrambling your brain function in a whole bunch of different ways. People with hearing loss are borrowing the auditory area to do visual tasks. So, what can we conclude from all this? This reorganization is taking place everywhere. Auditory area, visual area, memory area, and I didn't put it in here because it's not as relevant, but also the touch and feel area of the brain, the somatosensory area as they call it. So it's a complete reorganization. And this is just people with mild hearing losses. A lot of people with mild hearing losses don't even think they have hearing loss. So, the big question, though, is how can hearing aids and cochlear implants help this situation? Well, let's pause just for a minute on that slide before here, and let's talk about the cochlear implant a little bit. There are 3 users here who could demonstrate for you what they look like, but essentially a cochlear implant is for people whose nerve cells for hearing have stopped functioning well, and so they replace those nerve cells for hearing with wires, essentially. And those wires take the place of the little nerve cells firing little electrical spikes. And you can see a cochlear implant in place over there on the far right, and you can see how they insert under the skin the little receptor unit with the wire that runs down into the nerve cells for hearing. And I assume most of you have seen a hearing aid on the far left, so we don't need to talk much about that. So, here's the good news that we have for you today. People who have good scores on speech and noise tests, particularly the quick speech and noise test, are spared this brain reorganization. That's a major breakthrough. Good hearing aid programs that provide good speech understanding on this quick speech and noise test, or QSIN as they call it, are spared this scrambling of the brain from hearing loss. So it becomes all the more important to start thinking about what makes a good score on this test. And you can see on the right, you've got your poor hearing aid user who's still not using the visual area appropriately, as opposed to on the left, the good hearing aid user whose visual system has been maintained. So, like I said, obvious question, how do you score normally on this very difficult speech and noise test? Well, we did a study back in 2012, and we looked at that very question. You see, in this country, there are two different ways. In fact, worldwide, people tell me, because I was interviewed for an international journal on this topic, and the author was from Canada, and his data is from around the English-speaking world. He said it's not just in the U.S. where this practice takes place, it's worldwide. And what practice is that? Well, there are two ways to program a hearing aid for your hearing loss. The first one is we just enter your hearing levels into a computer, and then the computer makes the best guess as to what you need for amplification. And that, unfortunately, is the most common way hearing aids are programmed in this country, and I'll show you why that's a problem here in just a minute. But there's a second method that Nikki will be talking about in just a minute called real ear measures. So what you see here on this graph is the 6 major manufacturers that control the world market. Hearing aid 1 was Oticon, hearing aid 2, Phonak, and so forth. The big 6 manufacturers are shown here. And what we did is we got together a number of subjects who were longtime hearing aid wearers, and we had them listen to each manufacturer's best, most premium hearing aids in noise with this quick speech and noise test. And we looked to see how many errors they made. The longer the bars are, the more errors they made. So, the green bars were when they used the manufacturer's guess based on the computer thinking it knew how to correct your hearing loss. Unfortunately, it doesn't. It makes a lot of mistakes, and those mistakes are shown in poor scores or high error numbers on this speech and noise test, long green bars in other words. And so I reasoned that hearing aids probably, if properly programmed, could give higher scores. So we used something called real ear measures that Nikki will describe in a minute. But essentially it's putting a microphone at your eardrum and measuring how much amplification the hearing aid's actually giving your hearing loss. And we discovered that we were able to dramatically decrease the amount of errors these subjects were making. In fact, if you look over on the far right, this old thing, that was a 20-year-old hearing aid we used that I just programmed using the real ear system, and showed that if you rely on the manufacturer's computer best guess, you're actually better off buying a 20-year-old hearing aid than the brand new best hearing aids the manufacturers make, because it is the programming of the hearing aid much more than the brand or model of hearing aid that gets you a good score on this quick speech and noise test. So, you might think, though, your hearing loss isn't bad enough to need hearing aids right now. Well, remember, this data generated by Dr. Sharma showing the brain reorganization associated with hearing loss was people with mild hearing loss. They weren't deaf people by a long shot. These are people who just barely had hearing loss. Up there at the little top, you see those red marks. That's the mild hearing loss that these people had. Next. You might think, You already have hearing aids and you're pretty happy with them. Let's talk about hearing aid happiness for just a minute. This study was an interesting one. It was by Dr. Humes and his colleagues at Indiana University. They had 153 subjects, and what they did is they assigned them to 3 different groups. One group got real ear measures, one group just picked something out of a box that they liked, and one group, they put hearing aids on them that were essentially turned off. And the first 2 results aren't horribly surprising. Those who use the real ear measures, a microphone down at the eardrum measuring what the hearing aid was doing, were the happiest with the hearing aids. They wanted to buy them. This next group that picked what they liked out of a box was able to try different hearing aids until they found one they kind of liked, and they were a little bit less happy, but still, they were going to buy it at the rate of how many? 55%. Over half of them were going to buy the hearing aids, just picking them out of a box. But the group that really got my attention was the last group that were wearing hearing aids that were turned off. And this has amazing implications for sales of hearing aids. 36% of the people who had hearing aids that were turned off wanted to buy them for $1,800 a piece. That's a little amazing, isn't it? So when people say to me, I like this hearing aid just fine, I look at it askance, because I know that if you get 53 people together and you have them wear a hearing aid that's turned off, over a third of them is going to say it's a pretty good deal. I like it. I'll give you $1,800 per ear for this hearing aid. So my point here is that consumer report of satisfaction doesn't really mean much to me, because I continue to see data that suggests that it means nothing. We did a study that won an award at our American Academy of Audiology where we looked to see how much hearing loss people actually had, and then we gave them a long survey asking them about how impaired they thought they were. And come to find out there was no relationship between how much hearing loss they actually had and how impaired they thought they were. Now, you might say, well, if you would have given it to the spouses, they would have had a different answer, and in fact they did. They rated much more hearing loss than the individual who had the hearing loss themselves, because you don't really know what you're not hearing until you've heard it. And if you have a bad hearing aid program, you won't hear it. So you don't know you're missing it. But 36%. And, I think this has implications, as I said, for the hearing aid industry in general. If, for example, you were to take a vending machine, and those of you who are my age and older, remember the days of those cigarette machines. You'd pull that thing out and the pack would fall down. If you got one of those old vending machines and put it at Kentucky Fried Chicken, and in it you put a whole bunch of hearing aids that were turned off and put an $1,800 each price tag on it, you could sell, let's say you had 100 in there, you'd sell 36 hearing aids on average. Now you say, well, that's not a very good average, but put it in a big city where you get thousands of people going through the Kentucky Fried Chicken, you could sell 360 every time 1,000 people pulled the lever and bought one of the hearing aids and then brought it back. That's not a bad average, actually, because the people that own that machine are making quite a bit of money for just having you pull the lever and give them $1,800. So I know I've really gone over this point quite a bit now, but I don't really put that much stock in consumer self-report of hearing aid satisfaction or cochlear implant satisfaction. It's the same phenomenon. You don't know what you're not hearing until you've heard it. And to hear it, you have to have your hearing aid or cochlear implant reprogrammed. Or you might think, but my hearing loss was fed into a computer for a precise amount of amplification provided to me. The manufacturer would have you believe that. But we looked into that question too. We looked at 179 hearing aids from 24 facilities throughout the state of Oregon. People came into our clinic with hearing aids from other places, and we put them on the real ear system, measured how much amplification was being obtained, for their hearing loss and then look to see, is it appropriate? And what we discovered, not too surprisingly, is that there was almost no relationship to their hearing loss. For example, this graph here shows all 179 hearing aids. Now, if the programming was perfect, meaning that it exactly corrected the individual's hearing loss, the red right ear and the blue lines would be straight across at 0, meaning no error whatsoever. But you can see there is an increasing error of programming as the pitches get higher, which is the worst thing that can happen because most people have most of their hearing loss in the high pitches, yet the accuracy of the program is getting worse as you go into the higher pitches. So, getting back to my 36% number again, a whole lot of those people would have been perfectly happy with a hearing aid turned off, and there were a number of them in this sample of 179 hearing aids. Or you might think, I hear well enough with this hearing aid programming, but I got to remind you one more time, next slide, that maybe you're not doing as well with it. And let's skip this slide. Remember what Dr. Sharma said. If you don't score normally on this quick speech and noise test, you're not saving the brain. So it doesn't really matter too much to me from a medical perspective whether you're satisfied with the hearing aid or not. Sorry to keep throwing up this 36% number, but even if 36% of you had dead hearing aids, you'd still like them and be willing to pay $1,800 each for them. And I just pulled off the most recent article on this from Sanders and the group at Vanderbilt, but it's well known that the manufacturer's best fit isn't good. And if you want to actually program the hearing aid to the individual's hearing loss, you're going to have to make some substantial changes in the program above the manufacturer's best guess fitting from that computer to get what the individual actually needs. So now it's time to talk about that in a little more detail.
So I'm going to explain what real ear verification is. Like Dr. Leavitt said, a microphone goes down in the ear and it reads exactly what the hearing aid is doing inside your ear compared to your hearing loss. And how that works is we have in our clinic an Axiom, which is a model of a real ear, a piece of real ear equipment. There's also a Verifit RM500 and many others. We use the Verifit and the Axiom in our clinic. We put the microphone into the ear and then the hearing aid on over it. And the speaker over here, pointing to the arrow, yep, the speaker emits a sound, and then the microphone in the ear with the hearing aid is reading out what the hearing aid is picking up from the speaker. And then it shoots out a graph for us. The red line that you see on the left, that red solid line is the individual's hearing loss, and the dotted line is the target. That is the target that we're trying to meet for to correct the person's hearing loss, and the green line is what the hearing aid is doing inside the ear. So we're meeting target for this individual's right ear. Same thing on the left ear. This is blue is the hearing loss on the left ear. The dotted dash line is the full correction target line, and the green line is what the hearing aid is doing, and we have a full correction on both ears. This is what you want to see when you're getting your hearing aids fitted to you. You want to make sure you're getting a full correction. You want to make sure that they're doing real ear. A lot of audiologists or hearing aid dispensers will say, yeah, we're doing real ear. It's built into the manufacturer's software. That's not what you want. They're using the manufacturer's fit. You want to make sure that you have a little tickly tube going into the ear and the hearing aid going on over it. And then... What?
We told you so.
Yep, we told you so. Well, then maybe you need your hearing aids reprogrammed. Yes, if you have Oticon, Phonak, Resound, Siemens, Starkey, Widex, Interton, we can do reprogramming on those hearing aids. However, I got ahead of myself there. This study here, if you don't have good hearing aid programming, is pretty likely In fact, the study showed that 97.7% of subjects showed deviation from the real ear target, that target that I showed you, in excess of 5 dB in both ears.
I wasn't able to say it was everybody, but it's pretty close. 97.7. It almost was 98% of the people had wrong program.
And this was everyone in Oregon that we did. But here's some bad news. A lot of hearing aid manufacturers lock their software so we can't get into the hearing aid program and fix it using our real ear measurement equipment. And those companies are Beltone, Amazon, Miracle Ear, Health Innovation, Costco, New Ear, Audible. These manufacturers, we cannot reprogram them. They lock the software. We've tried to get our hands on a couple of them, and they just say, no, sorry, we have a contract with Costco. We don't have a contract with you. We can't give you that software. So it's really unfortunate to those patients that come in, say they're not doing well with their hearing aids, and they get a hearing test from us, and then they take out their hearing aid, and we find it's a Costco hearing aid or Beltone or Miracle Ear, and we have to break the news to them because they had no idea that, sorry, we can't reprogram them. You either have to buy new hearing aids that can be programmable wherever you go, or go back to Costco with your new audiogram and see if they can fix it.
Hope they make a better guess would be my statement. Because they're just guessing. And just as an aside about that guess, and those of you who have a book, if you can't remember those brands, they're on page 55 of the book.
But new hearing aids are very expensive. We do realize this. We have been, well, Ron taking that over, actually.
But let's talk about hearing aid pricing. Remember, first of all, that 36% of people are willing to buy $1,800 hearing aids that are turned off. So that's a good sales technique for some facilities, I assume. But as Dr. Humes and his colleagues pointed out, when they bought a state-of-the-art hearing aid back in the year they were starting this study, I think it ran for 3 years, so it would have been 2014, the development cost of that hearing aid, they say, was $100, and the VA and Costco were buying in between $250 and $500, and I heard the head of the VA audiology division recently at a conference say it was actually $300. That's the magic number. They're paying $300 for things that some of them we have to pay over $2,000 for. So why do they get this kind of discount? Well, it has to do with volume purchase, sort of, because the VA purchases 19.3% of hearing aids in this country, and Costco another 13%, or taken together, they're buying a third of the hearing aids in this country. But that begs another question when you go to the next slide. Okay, so they're buying a third of them. Where are the other 2/3 going? Well, the answer is it's independent practitioners and buying groups. So why is it that the group that's buying way more, almost by a factor of 2, are paying so much more for these hearing aids? And I have a very good answer to that. You see, one of our national associations reasoned that we should kind of all get together and make use of this 53% majority interest we have in purchasing hearing aids. Makes a lot of sense. But what they decided to do was not to buy the big 6 hearing aid companies, Oticon, Phonak, Frisell, Siemens, Starkey, and Widex. Instead, they decided they would buy some boutique company called Earventure. And Earventure hearing aids, we got a bunch of them to try them out, are so whistle prone that even a mild hearing loss is hard to control. They're just screeching away like the first digital hearing aids ever made, because they don't have the more sophisticated feedback control circuitry, so you can't get a full correction without the things screaming like a banshee on your ears. So we suggested, and 50 people from this group group signed a petition, sent it to them, that they forget about ear venture and move on to the big six, who make good hearing aids: Oticon, Phonak, Resound, Siemens, Starkey, Widex. By the way, Siemens was sold. For a while it was called Savantos, and then it was bought again, and now it's called Signia. So if you hear Signia, they're really Siemens hearing aids. But my point is this: we had 53% of the market. Why don't, since this group is purchasing these hearing aids in bulk anyway, why don't we buy good hearing aids? And they said, we'll take it under advisement, and then the board decided they weren't going to do that for reasons not clear to me, or any of the other.
Because they have money put into ear venture, unfortunately.
Yes, well, it's easy to take money out. Just look at all the companies that go bankrupt all the time. It's easy to forget about bad companies. So what's next? What do you do now, you might ask? Well, don't do that. That's one part of the answer. But I'll tell you what, I think I can do better than this without ever seeing any of you in our clinic. I bet if you just send me your hearing test results from somebody that knows how to do them, that I can program that hearing aid closer than that right there. Now, my assistant, who's sick today, said that's a pretty low bar, because look at how horrible those fittings are. They're almost turned off for some of those subjects they were. But my point is, if this is going to become the norm, and it is common practice in this state, we have shown it quite convincingly, then I think we can do better without ever seeing people. Just send us your hearing test results. I can program that hearing aid closer than that. I'm virtually sure of it. And with something called remote programming, I can make little changes once you get them on your ears. Now, you might ask, though, but won't that be, if you just buy them sight unseen, you never see the person? So you ask an obvious question. Aren't you going to be overlooking a lot of medical programs, medical problems if you do that? Well, not according to the FDA commissioner in the division of ear, nose, and throat technology. He maintains that the medical evaluation requirement does not appear to provide any meaningful benefit to hearing impaired people.
Adults for several reasons.
Adults for several reasons. Next. Good, yes. First, he said, the National Academies of Engineering, Science, and Medicine, and this is the group that advises Medicare on what to pay for, so you can forget about Medicare ever paying for hearing aids, because this guy has pretty much made sure that never happens. The National Academy of Engineering, Science, and Medicine Committee conducted a thorough review of the literature regarding medically treatable causes of hearing loss, as well as reviewing data from the Veterans Administration and the Department of Defense. And they discovered that the
serious causes of hearing loss requiring urgent attention are very rare.
Very rare, he said. And when they do occur, they often present with symptoms such as ear drainage or pain that would get most individuals to seek medical attention anyway. Well, that didn't sound right to me, because, I've been an audiologist for 40 years. And so we looked into this. The next 86 people, next slide, that came into our clinic, we just made a record of what they had. So this is based on 86 individuals that came in over a 3-week period. And here's what we found. And boy, this is an eye test. I should have worn my glasses.
No, I can.
2 of them had holes in the eardrum. And there's a picture of an example of that. Did it with a Q-tip. Punctured a hole in their eardrum. 21 of them had this. Complete blockage of the ear canal with earwax. They didn't need hearing aids. One guy came in, the secretary came back and said, "You're really going to have trouble talking to this guy. He can't hear a thing." Both ears were plugged like this. As soon as we cleared him, he said, "I can hear." And he could. He went back out, and that was that.
Had normal hearing.
The third one, how many of those?
6.
6 of them had something called otitis externa, or swimmer's ear, and it causes the ear to swell up, and that's sort of like a bad example of it, and that pussy goo oozes out. But still, and it's not life-threatening, and you're not going to. It doesn't require surgical intervention, but it should be followed up with some antibiotic. How many of those?
One.
One of them had Meniere's disease, a problem that creates severe dizziness, fluctuating progressive hearing loss, and horrible nausea, and a lot of ringing in your ears. How many of these?
For the hearing asymmetry,
Two
or
of-
you wanted
two of
for?
them?
Yeah,
Two of
two.
them. Two of them had hearing asymmetry, meaning that one ear was a lot different than the other for no apparent reason. And that is a red flag warning for an acoustic tumor. In fact, that's the most consistent warning that the Mayo Clinic group found, is when you have a big difference between ears. For no apparent reason, that is the most consistent red flag of an acoustic tumor. The next group, how many?
4 high fall risk.
4 of them, I was pretty sure was going to have a major fall within the next year. And I sent that letter to their physicians saying so, suggesting physical therapy, because remember, that's the #1 cause of accidental death. And here's a depressing statistic. If you fall and break your hip and you're over 65, how likely do you think it is you're going to be dead within a year? 50%. 1 in 2 are going to be dead within a year if you fall down and break your hip when you're over 65. So don't do that. And if you've got a fall risk, let's get you to physical therapy, and let's do some balance exercises and some strengthening exercises, because we don't want half of you dead. I mean, that's a pretty high mortality rate for a problem like a broken hip. Next, what's next?
1 for fungal infection.
Oh yeah, this is one of my favorite pictures. Can you bring that one up? Fur in the ear. We see a shocking amount of fur in the ear, and that can be killed with an antifungal medication, but you don't want to just leave it, because it can really flourish. And it's not, you know, you would think, why don't you just get in there with your curette and pull it off? It's really growing into the skin, and when you do, you tear off a piece of the skin to go with it. Those do not remove as easily as they look. This looks like you got a piece of lint in your ear, but they're not. Next, how many were those?
7 in-office hearing aid repairs.
Yeah, a lot of people came in with just hearing aids that were blocked with earwax, or just needed some sort of attention, reprogramming, for example, or something. They didn't need to buy new hearing aids. They just needed reprogramming or minor repair on the ones they had.
Precancerous lesion on the pinna.
Yes. This is
2.
real common. We see a lot of this. That's a basal cell carcinoma, and in 90% of cases, they never metastasize. They're not going to eat into your temporal bone and cause meningitis and kill you. But if you're in that unlucky 10%, they can. So we like your dermatologist to at least take a look at them. Most of them, they say, nah, we'll just watch it. Occasionally, they burn them off, but still, it's not something you just want to overlook. And this one person, I know how many there were of this, she had gone to a number of places that didn't have any medical interest in her. In fact, I've published an article on this very person in a book from Washington University Medical School. It's soon to be published. And the title of the article was, "I Just Want Hearing Aids Now." And she made it very clear to me she didn't want to discuss anything about her hearing health history, because she had already been places and talked with people about it. I insisted, actually I said, then we're not going to do anything. You need to go home. I'm not going to do that. I'm not going to just hang a hearing aid on you like it's some sort of a decoration on a Christmas tree. So off she went, and I thought that was that. But a few weeks later, back she came. Okay, I've decided I'll talk to you about it. You see, I've had this dizziness, and it's really affecting me. And when I go out walking, things pass by me, it makes me dizzy to see things moving in my peripheral vision. And I'm finding that it's limiting my activities. And guess what? She had a huge difference between her ears. Very asymmetric hearing loss. So I said, well, we're not going ahead with hearing aids today either. I'll do a hearing test on you, but then I want to see an MRI. Off she went again. But a couple weeks later, back she comes. Okay, where do I go for the MRI? So I sent her up to OHSU, and they couldn't get in to see her, so I sent her to Good Sam in Portland, to the Balance Clinic. They did a complete workup, and they said, we want to see the MRI too. And they did, and there it is, a big tumor. In fact, so big that they said, OHSU said, we don't want to do this. It's so big that we're afraid we're going to affect other things, and that she doesn't really have any good options ahead of her. So I called Mayo Clinic, because this is one thing they do a lot of, and they said, oh yeah, you're going to have to get it out or it'll kill her. So I brought her back in, and we had that conversation. And she said, well, I'll think about it. Isn't there any place locally I can get it done? And I said, no, they're going to have to go into your brain to do this. This is not a simple operation. You want somebody that does 200 of these every month. That's Mayo Clinic. You want to fly to Rochester, Minnesota. I know it's inconvenient, and have them do it. Well, that didn't happen. She died of that acoustic tumor. And then we had these bony exostoses. Those of you who have swum, who are swimming in cold water many years ago when you were young, likely have some of these in your ears. They make the bone grow. They're called exostoses. And in this case, it's almost entirely closed off the ear canal. But they are not easily removed, but rarely do they completely close off the ear. And I would say to you, having seen attempts at removing these, you're probably better off just leaving them alone, because the scar tissue then grows like wildfire and has to be pulled out all the time. But again, your physician should know about this, and we should keep an eye on it. It warrants medical monitoring. Next.
Cognitive issues, one.
Yeah, one person. How many of you are 100% sure right this minute that you can spell the word world backwards? W-O-R-L-D. How many of you think for 100% certainty you can spell that backwards? Good. If you have your hand up, good for you. If you don't, you may be in that category, because that's one of the questions. In fact, that's the hardest question on the mini mental state exam. It's a quick screening test of cognitive issues, and you'd be surprised how many people cannot spell the word backwards.
I don't know, Ron. The other one is count backward from 100 by 7.
It's the same. It's the same one though. If they're not good with math, you use world backwards. Mm-hmm. So only one person failed that, but again, physician needs to know that there are some cognitive issues here. And if it's dementia, if it's Alzheimer's, there are certain medications that can slow the progress. You want to know about these folks. How many of these?
2 otitis media.
Now this is unusual, but we see a lot of it. Adults are not supposed to have fluid behind the eardrum. That's something that kids have, you know. When I used to be the head of the hearing program at Tucson Unified School District and Amphitheater School District and the Austin Regional Cooperative for the Hearing Impaired and the Tacoma School District, we saw in poor schools particularly about 1 out of 4 students had this problem in their first 10 years of life. But you don't think of adults as having this problem, but here they were, 2 people that had fluid behind the eardrum. And it needs to be, a lot of times, treated either with antihistamine or with a little drain pipe in the eardrum to get that fluid out of there, because it creates quite a hearing loss that's highly treatable. And if you don't get it out, it can get infected and cause all kinds of problems, not the least of which is meningitis. So again, medical follow-up. Then there were just simple hearing aid reprograms. How many of those? 2. Yeah. Fortunately, we were able to just reprogram these people's hearing aids to where they fit their ear. And Eustachian tube dysfunction. Yes, that retracted eardrums. Before you get fluid, if you can't pop your ears, the eardrum starts getting sucked back into the middle ear space, and it creates a hearing problem. And that, again, is easily treated, usually with antihistamine to open up the Eustachian tube, the drain pipe again. And what else? Oh, yes, conductive hearing loss. How many of those? There were just 2. 2 people had medically treatable hearing losses. One of them was a university professor, had a doctorate. You'd think, well, no, she would, and she'd been wearing hearing aids for a long time. And I said, say, why are you wearing hearing aids? And she said, because people have always told me I needed them. I can't hear. And I said, well, it's true. You can't hear, but it's medically treatable. Those, go back to that if you would.
Sorry.
Those little arrow marks show what your nerve cells are doing. Those little X's show what happens when the sound has to go through your eardrum. There's something behind your eardrum blocking this. And what it was the bones were fused, the 3 little bones, the hammer, anvil, and stirrup. So I sent him up to OHSU, and son of a gun, she came back with normal hearing. And I said to her, so, you've been hard of hearing, quite hard of hearing for all these years. That must have been quite a shock to go from a moderate hearing loss to normal hearing in a single day. And she said,
no, I got used to it, is what she said. And before she saw us, she was wearing hearing aids for how long, Ron?
long time.
10 years or so. So she bought several hearing aids when all she needed was surgery, and it restored her hearing.
And that's not that uncommon. Next.
And then 32 of them had no medical concerns.
Yep. So not even half of them. Now, I agree that none of these things, except for the one, and maybe the 2, otitis media untreated, potentially could kill you. But other than those 2 problems, none of them are fatal, and apparently in Dr. Mann's eyes, unless it's fatal, it's not that much of a concern. But I think those other things shouldn't be overlooked. And it's interesting when you look, I got to wondering, who is this guy anyway? Well, he's head of the Ear, Nose, and Throat Division at the FDA, but he's an ophthalmologist. He's an eye doctor. Go figure that. He's never seen a person with a hearing aid, I'm willing to bet. Certainly not in a professional capacity. So, David, what have we learned so far?
Properly programmed hearing aids may allow the hearing aid user to score normally on the quick speech and noise test. This unfavorable brain reorganization occurs as early as 3 months after the onset of even a mild hearing loss. Your hearing aid very likely isn't appropriately programmed to your hearing loss. It will not prevent this unfavorable brain reorganization. And if you got an over-the-counter hearing aid, God knows what would happen. That's my own editorial comment. Proper hearing aid programming requires real ear verification. Otherwise, your hearing aid program will look like this, not this. What about all those organizations that support non-programmable hearing aids like Costco, etc.?
And the reason I left that one for you is you may notice there's one there that you were president of the Portland chapter for many years and actually worked at the national office. I'm referring, of course, to the Hearing Loss Association of America. They think this is a good idea, which is very ironic because I don't know if any of you have ever been to a Hearing Loss Association of America national meeting, but I would say roughly, and you can chime in on this, probably of those people, 80% of them have severe to profound hearing losses.
That's, very significant.
These hearing aids won't do them, they won't even know they're turned on. I see Sherry back there nodding her head because she was one of the subjects that listened to these non-programmable hearing aids that were highly recommended, but I'll let her talk about it in just a minute when we get to that slide. But yes, the world's largest organization of hard of hearing people thinks that this is a good idea.
Let me just comment here. By non-programmable hearing aids, what Ron's referring to are the over-the-counter hearing aids that you can buy online, correct?
You can get them at Walmart, Amazon. Yeah, you can get them at Walmart now. Walgreens, I think, has a few.
But you may notice there's some very distinguished groups here besides the Hearing Loss Association of America. You've got your Johns Hopkins Department of Otolaryngology. Good grief. They were rated the #1 the ear, nose, and throat program in this country. The National Academies of Engineering, Sciences, and Medicine, the group that does Medicare advising as to what they're going to pay for. The Academy of Doctors of Audiology, which I see as something of an embarrassment. I won't editorialize about what's happened to that group. Indiana University, a major training program for audiologists. These are not just little backwoods boroughs. These are major organizations. Next.
Well, wait a minute, let me just comment further on that. My biggest concern with this is that rather than doing in-depth studies ahead of time to support the fact that over-the-counter hearing aids make sense, they sort of theorized or hypothesized that this would be an acceptable thing for people with mild to moderate hearing losses. And then they got the FDA to go along with that. Hearing Loss Association of America, the National Hard of Hearing Group, they're supporting this stuff without really any in-depth studies to say this is a good idea. So my contention is, if it winds up that it is not a good idea, you've done God knows how much damage, potential damage to people as a consequence. How much money has been wasted buying these particular items which may not work. So I find it very upsetting that they did all of these types of things, passed a law to the effect that this was allowable, etc., without the studies to really support that.
Well, what they did, they being the National Institutes of Health, made money available through the, National Center for Deafness and Other Communication Disorders. Millions of dollars available to prove that this idea of over-the-counter hearing aids would work. And two of these organizations cashed in on it, Johns Hopkins and Indiana University. And we'll talk a little bit about their two studies, because they were the classic studies that proved that this was a good idea.
Yeah, but didn't they do those studies after the law had already been passed?
No, they got their money first.
They got their money first? They did the studies ahead of time?
I'll show you.
Okay. I stand corrected then on that.
But if you use these things, your brain's going to look like this. And I can prove it. There we go. So I took a look at, Johns Hopkins recommended 3 hearing aids that you can buy online. One was called the Sound Hawk, one was called the Etymotic Bean, and the other was called the Clear Sound CS150. Those are the things that they bought online and said they work just as well as state-of-the-art hearing aids. An Oticon Nera was the hearing aid they used that was state-of-the-art, and it was. And so I thought, well, that's interesting. And then the group at Indiana University said, in addition to that, if you just pick hearing aids out of a box that have been pre-programmed based on a guess of what you might need, you'll end up about as well as if you had the real ear measures that we've been talking about. And they said it was true, both the groups, for mild and moderate hearing losses. But as I looked at their data, it became apparent to me that those people that they had used for their 153 subjects at Indiana University and for the 39 at Johns Hopkins essentially had borderline normal hearing. So I thought, well, but they said it's going to work for moderate hearing losses, so I rounded up some people with moderate hearing loss, like Sherry back there being one of them. And I said, okay, let's try these things out, and let's see how you do on, you guessed it, the quick speech and noise test. What are your scores? How many errors are you making? Well, remember, the longer the bars, the greater the errors. Okay, so you can look at each of these different types of hearing aids. The CD was the consumer decision model of Humes and the group at Indiana University. You can see the SoundHawk data. Maybe you can. Is it big enough?
It's big enough.
Yep. And you can see the bean, the etymotic bean data. And what we discovered, to sum it up easily for you, the longer the green line, the better you did. So the long green lines means you did really well. And you can see there's not much green line on the etymotic bean, or the sound hawk, or the consumer picks one out of a box method that Humes and his colleagues at Indiana University suggested when you use people that actually have moderate hearing losses. By contrast, when you actually program these things to people that have moderate hearing loss, you get a big green line using my real ear system. So real ear measures, and this is the one we're trying to get published right now, by the way, that we're taking forever to do. It's been over a year of corrections and little this and little of that. But anyway, soon this hopefully will be in print in the exact same journal that the Indiana University used when they published their results, saying this was a good idea. But it certainly doesn't look like it from our data. Next slide. Now, you may be wondering, so if you just get a good program, is it going to save your brain? And the answer is no. There's a whole bunch of variables that seem to contribute to this, and we're looking at that right now. In fact, it's my assistant's school project for this quarter, so hopefully by June we'll have it all completed, and you can take a look at the characteristics that actually do make you score normally on that speech and noise test. But I will say this, the first thing that all of them had in common was the hearing aids were programmed to their hearing losses with our real ear system. It's like you can build a house that's pretty nice, but it has to have a good foundation. And the foundation of that normal score is an appropriate program on your hearing aid so you can score normally on this quick speech and noise test. So, what else is necessary? I'll get back to you on that probably in July, as soon as we've got all the data in. I got a pretty good idea now, but I don't want to speak out of class. Now, did I say that cochlear implants can also do this? Can they be protective of brain function? Remember the cochlear implant, the surgical procedure that puts wires where the nerve cells used to be for hearing? Yeah, let's take a look at, again, Dr. Sharma's data on cochlear implants in children. Next slide, please.
You don't want to review cochlear implant?
I think I did.
Okay.
So, yeah, they are. Let's take a look at her data. You can see, perhaps, that the brain, those good cochlear implant users, and I'm going to talk a little bit about what that means, who scored well on this auditory verbal test, were spared this brain reorganization. So even cochlear implants on people that have virtually no hearing can be protective. And cochlear implants have an advantage over hearing aids. Hearing aids are tied to something called the half-gain rule, meaning that if you have an 80 decibel hearing loss, I can only bring it back to about 40 hearing level. But that's not really enough to do normally, a normal score on the speech and noise test. But once you get a hearing loss of 80 decibels, studies have shown that you have a 4-time greater likelihood of having a good outcome with a cochlear implant than with a hearing aid. And I can explain why that is. Because cochlear implants are not tied to the half-gain rule. So if you have an 80 dB hearing loss, I can bring you anywhere I want, with a little caveat that I'll show you in just a minute. But the cochlear implants, they don't care about the half-gain rule. Just turn it up until you can hear really soft sounds. It's even true for people that have deafness in just one ear. Cochlear implant on a deaf ear when the other ear is normal, if you can imagine that, will give you back normal brain function. And worrisomely, just one deaf ear causes this brain reorganization, even if your other ear is normal. So it got me a lot more interested in doing something on people who have one normal ear and one impaired ear. Next slide. But what about adults? And that's a big question. Essentially, this sentence from the Washington University Medical School article said that it could be possible that adult brain reorganization is different than children, but that's one of the research needs they're looking at right now. I, before doing this presentation, called up the lead author on this paper, though, and we spoke for a half hour on this topic, and we had a real commonality of interests in terms of programming, and that comes here in the next slide. What we're going to do with adult cochlear implant users in the meantime. As Dr. Holden and her colleagues at Washington University Medical School in St. Louis say, and by the way, they do hundreds of cochlear implants every year, so this is like the cochlear implant center, and they've been compiling data for over 20 years on what makes a good outcome with cochlear implants. And what they said is that we found from early studies that if you could hear levels less than 30 decibels when we do a hearing test on your cochlear implant, you're going to hear some soft sounds, but not all of them. Specifically, the next slide, if we only bring you to a 30 decibel level between the speech range sounds with that cochlear implant, you're only going to hear 75% of speech sounds. By contrast, if we can bring you to 20 decibels, you can hear 97% of those speech sounds. So it becomes very apparent that you want to bring the cochlear implant thresholds to 20, not 30 or 35 decibels, because you're going to hear a lot more with that program. To which I said to her, I virtually never see that. And she said, funny you say that, because we travel nationally giving lectures on this topic, and we're invited to various facilities throughout the country to look at their programming, and we don't find it either. In other words, there are a whole lot of people who have cochlear implants that are turned down too softly, essentially. She thinks it's an epidemic problem. So, what are we going to do in the meantime? Well, we're not going to put you down there. Those little green marks are not where we want it, because if you look, you can see that that would only allow you to hear a few speech sounds. The ones above the green marks are the ones you can hear. The ones below are the ones you still can't hear. So why would you want to wear a cochlear implant that's essentially programmed at 35 to 40, because you won't be able to hear much with it. But this is what I see as often as I see bad hearing aid programs. What she discovered back in 2012? That's a really small number. 2011. What she and her colleagues discovered is if you turn up certain models, companies of cochlear implants to these levels, the microphone in the processor, the little thing that goes over your ear on the outside, was making so much noise that you couldn't hear the soft sounds. So you were having circuit noise, not actual hearing. And therein lies a major problem, because you can't overcome circuit noise in the system. And son of a gun, they discover that these things have a problem. You cannot get the threshold you want without circuit noise. And I remember trying to push yours up until you heard circuit noise. I thought, gee, that's odd, because we weren't pushing that hard. So here's what they did. And this is the next slide. Shows what resources they have. They brought in their electrical engineering team, and they took out the microphone in the existing processor and put a high fidelity microphone in its place. And they discovered that, next slide, they were able to, so they changed microphones. Next slide. They discovered with this studio quality dynamic microphone, next slide, they could get 10 dB better thresholds at every single frequency. So the company, I almost said their name, the company read this, flew their people out to St. Louis, said, let's see this microphone and let's see your data. Prove it to us, in other words. They said, okay, come on. And they did, and they got back in that plane, and they rushed back to where their company was, and they changed out those microphones in 2012, because this is a major problem with all three companies that make them. And one company is worse than the rest, and still maintains that those thresholds don't matter. It doesn't matter what the thresholds are, it's how people do. Well, sorry, those thresholds are tied to how well people do. Their evidence of this is pretty powerful. But the companies all had problems with the noise in their circuit from their microphones. So much noise that you couldn't hear the soft sounds through the circuit noise. Well, happily, this group that sent their people out went back and changed it immediately, so now they can. But there's still one company that's held out that won't do it. There's only three companies where you can get cochlear implants in this country. Only one is now holding out on this microphone problem, but they still have it. So that's a little upsetting, and there's news for all you cochlear implant wearers that got my attention, certainly, but they proved that was the source of it. It was the microphone in the processor was noisy. So there you have it. So to summarize, Nick.
To restore normal brain function, hearing aids and cochlear implants must be properly programmed. Hearing aids and cochlear implants are often not properly programmed.
Usually. I should have
Usually. Are usually not properly programmed. Self-diagnosis and self-treatment of hearing loss doesn't work either in terms of essential proper speech sound audibility or medical referral. We disagree with Dr. Mann from the FDA regarding medical necessity. Hearing aid prices need to be lowered to the majority of providers, not just to the minority of VA and Costco facilities, each with their specific limitation.
For example, some of you aren't veterans, so you can't get hearing aids unless you're service-connected to hearing loss or tinnitus. For example, some of you don't want to go to Costco and get a off-the-shelf hearing aid whose software is locked.
In the interim, you are not well served by delaying action on your hearing loss. You want to get in as soon as you can, as soon as you notice that you're having trouble with your hearing, or your spouse notice, hey, you're not hearing as well as you used to. You keep missing conversations, or maybe you stay home more now because you have trouble in group situations. So start now, get your hearing loss checked, and see what we can do about it.
Remember the 3-month rule. That's all it took. 3 months, mild hearing loss, or even 1 ear hearing loss.
And did you know, on average, patients with hearing loss wait 10 years before they ever do anything about their hearing loss?